Welcome to the Crisis Response Podcast, a show about the regular folks who are tackling major problems and transforming how communities watch out for each other. I'm Jason Friesen, and on the show today, how Mark Jenkins turned his frustration, ignorance, and passion into the Connecticut Harm Reduction Alliance, a pioneering harm reduction organization providing crisis response, social services, outreach, and education to nearly half the state of Connecticut. Good afternoon. Today we are joined by Mark Jenkins, the founder and executive director of the Connecticut Harm Reduction Alliance, based in Hartford, Connecticut. And Mark is going to share with us today his journey, having started the Harm Reduction Alliance many years ago, and through the path, what they've done and what they're doing today and what they hope to do in the future. Welcome. Great to have you, Mark. Always a pleasure.
Thank you, Jason. Glad to be here.
Absolutely. So we've been working together for a couple of years now, but I'm wondering if you could share with our audience, what does the Connecticut Harm Reduction Alliance do? What's your mission, your goals, your objectives?
The Connecticut Harm Reduction Alliance, formerly the Greater Hartford Harm Reduction Coalition, is a harm reduction organization. It is the only harm reduction organization in Connecticut by mission, vision, and value, meaning we encompass harm reduction best principles in its entirety. It's all we do. It's not a submission of our organization. This is what we eat, sleep, and drink. And it's to help individuals reduce the amount of harm caused as a result of their actions, whether it be generally around illicit substance use, commercial sex work, homelessness, to try and help individuals reduce the amount of harm, caused by some of those actions through advocacy, education, information, and equipment, materials, providing materials. That could be anything from syringes to safe sex supplies to shelter referrals. We provide some case management around housing. We have now evolved to encompass also a full medical model. Where we have vaccine storage. We have 2 nurses on duty. The organization has grown over the years from the back seat of, at the time, my GMC Safari with my, I guess, one pay. I was looking at a grant application this morning, and I kind of chuckled because we had one full-time volunteer, and one full-time staff. I don't know if that was me or the young lady that I was kind of my administrative assistant, if you will. At the time, we had 15 volunteers. I think we did somewhere around 57,000 syringes annually, and we might have had around $63,000 that we brought in for income that year. And I'm saying, we've amassed now a 2-story former law office, another 2 brick and mortar locations here in Hartford as well, an RV, a fleet of 5 minivans, 30 staff. We go through about 70,000 syringes a month. We respond to, anywhere between 10 and 25 overdose calls a month, depending on the month. Active scenes. We're either state's largest hand-to-hand distributor of naloxone, in addition to fentanyl test strips, full drug checking. I don't know if I mentioned we now have an RV also. We're in the field, in the street now, prior to the new outreach team, which is going to be focusing on the fast track. We were in the field 14 hours per day consistently That's going to increase to about 19 hours a day in the field. Well, if there's some overlap, so I'm going to back that off to about 17 hours each day, Monday through Friday, that we have people in the field trying to provide services in one form or another. So the organization has taken hold. We serve approximately 40% of the state reach or either supported by our services. So it's a work in progress.
It's quite an impressive work in progress. I mean, that's a huge accomplishment in all these different areas. If you could share, how did this all get started? You're the founder. You started this. You said with one administrative assistant. What led you to start a harm reduction organization, particularly at a time when harm reduction, to say the least, wasn't widely accepted at all?
Frustration, ignorance, passion, and I don't know which order those come in. I think ignorance might have led the way. I had no idea what I was getting myself into. But I had worked for, a couple of the organizations over the years, and outreach, as it were, to marginalized populations was beginning to, it changed. It changed. I also always felt more could have been done in various neighborhoods, uh, and to have a further reach. My pleas were always fell on deaf ears, or tunes of like, well, help us find the money, and maybe we can look at it. And quite, literally, I I felt, at the time I was working for a gay white male led organization, an AIDS service organization, and they just didn't have our best interests at heart. And when I say our best interests, that's the people in the street that I serve. And I felt I could do a better job. Um, again, that was what I knew from my years of doing the work up to that time. Unfortunately, I did not have an idea just what it would take to launch the effort. So that's where I went into it. And it was the passion, and my belief system that we could do this is what kept me at it for 5 years without a paycheck.
And what were the first steps you took when you said, I'm going off. I'm going to do this. Start your own effort. What were the first steps that you took?
I put it on Facebook, uh, so that committed me. Once I put it on Facebook, it was like, and and it was deliberately, my statements were aimed at a couple of individuals from that aforementioned organization that had basically said, who better to do this work? This is what I am. This is who I am. I'm a harm reductionist, you know, and who better to serve my community than someone who is vested in the community, someone who has an invested interest in the community. And I believe that from there, I came up with a name. I spoke to a few people about being on my board. There are quite a few people who thought I had lost my friggin' marbles, because this other organization, if you will, had been doing that work at that time for, probably since they started, syringe service programs in the state. And, again, knowing what I knew and what I still know is that so many organizations get money and just, I'm not going to say they don't do anything, but I'll put it this way: if I've gone from the newest organization to lead the state in just under 8 years, um, and I'm no Einstein. Uh, our work shows our work, and their lack thereof is the proof.
So you posted on Facebook. You basically hang your shingle, right? That's the modern way of hanging your shingle. And you start putting together a board. And what services do you focus on first? Where's your point of entry, so to speak?
Syringe exchange, bare bones, street outreach, syringe exchange, referrals to drug treatment. Uh, that was it. I had connections around the country, many of whom are, on the wall behind me. Uh, I see Shiloh back there behind me and Dan Big. These are people who supported our work. These are people who had supplies, uh, and could support. And then the state, also having worked for those organizations, when I made that announcement, they said, "Well, listen, we'll give you some supplies in exchange for data, and we can't give you any money, but we can give you some supplies." And so it began that way. Just really, I was at the time I was still working for Blue Hill Civic Association, and I'll never forget walking into that office because we'd moved from when I first started working there. And when we moved to Albany Avenue, uh, when we moved into that new space, it was the same space that the Urban League's community health program existed in a program by which I gained access to a treatment center, which eventually led me to Willimantic. Uh, so it was kind of a full circle thing, if you will. And there was something, I gotta tell you, was something spiritual about that room, about that office, about the moment where I knew something magical took place, something spiritual took place, and that it was the beginning of something. And again, I'll say to you, who knew? Who knew? Who knew that Greater Hartford would begin to do the work it did? Because of Dan, we had access to Narcan, to naloxone at the time. Because of Shiloh, I was able to have a pallet of syringes dropped off, so that we had other ancillary supplies, the safer smoking kits. Shiloh shipped those to me, you know, uh, and having that background as a DJ, I knew advertising and branding from that street approach and access to inexpensive flyers. So I began branding. Everything I wore had that brand. I developed that brand. I put some small money into the label development, which you see right there hanging behind me, GHHRC. Uh, and from there, everything had that brand. And it was like, you know what? Show up everywhere. Show up, be seen, make it known. Everything I wore had that logo on it. And I ate, slept, and drank it, and it was just day in, day out, week in, week out, and for several years of networking, of having the longest continually run, because naloxone became legal at the layperson level in Connecticut in October of 2014. Well, I already had it. You know, it became legal, but nobody had any. You know, even the people the state hired to begin to do some of this stuff, like I gave them supplies. Like, who the fuck is this guy? How did he get this stuff? And it was kind of resisted and resented. You know, um, But even from there, I began doing trainings and holding and hosting forums, town halls. And it was just one of those things where I implanted myself there to say, this is, this is what we do. This is how we do it. And we're here. We're not going anywhere. And it was that mentality that just kind of eventually it caught on. And as people began to hear of and understand or learn about harm reduction, well, guess who was that person? And don't get me wrong, we had that same organization, you know, that uh, that I had the resentment with in the beginning. They did their best to keep their foot on my neck, uh, to keep me out of places, to use their political leverage and everything else, uh, to keep us out of the work. But it was just that continued, that you know, that just dogged persistence, the passion of doing this work, and the fact that, I had the history, the experience, the connections, across the country. It took some time, but eventually it went over. And the relationships with, law enforcement, with state and public health officials, all of it began to pay dividends.
So that's a really impressive journey, and it sounds a lot like many community response organizations have gone through or are going through. I want to come back to the law enforcement relationship, but one thing you mentioned earlier was that you were talking to the Department of Public Health, and they said we can't give you money, but we can give you supplies, and in exchange they wanted data.
Mhm.
What kind of data were they looking for?
Well, fortunately, uh, it was the data at that time was a fairly simple lift. It was a unique identifier made up of four initials of the individual's name, the first two letters of their first name, first two letters of their last name. Then it switched at one time and became the first and third letter of their first name and the first and third letter of their last name, and their date of birth and their sex and zip code. And it just got every round, it got more complicated of how. So we just adapted for the sake of our participants, uh, and our brain health as well, our mental health, uh, that we've stayed at the same first three letters of your first name, first three letters of your last name, 8-digit date of birth, you know, and do it that. And so everything else was, and again, every time the CDC or SAMHSA changes something, so Department of Health is one part of information. And now that we're the first harm reduction organization to be funded by Mental Health and Addiction Services, so there's a different set of information there. So and the two shall, and as I say, the twain shall never meet. So it's a process, but we've navigated it. But we in the process have learned the importance of that data.
So the data they were looking for was data of beneficiaries, people that you were providing clean syringes to, or where
The
overdoses were happening.
individual, I'm trying to see if I have one in front of me, which I don't. Uh, I don't. Matter of fact, I can't even tell you, Jason, the last time I filled out an intake, which is, a very good friend of mine. That's what he said. He said, Mark, I only see, and that he was Lee Hunt, a gentleman I'm forever grateful to, because he gave me my first office space within his organization and said, as long as you don't screw up, I'm going to support you. And he did that. So we have always had a presence and a professional presence far above our income, always far above our income. And he said to me, Mark, I only see one problem with you and this work. He says, you like to help people. He said, you sincerely like to help people, and your position is going to take you away from that. He says, as you develop this organization, it's going to take you away from doing the very thing you like to do. He said, and that's where you're going to have to find, your ground, your common ground. And he was right. I've been at this desk on meetings back to back. God forsaken Zoom, WebEx, and today is Zoom, WebEx, and what's the Microsoft one?
Teams,
Huh?
teams.
Yeah, God Almighty, Teams. That's the worst of them. But I do know, I can tell you who we see, what we see, how we see as a whole, and then by vehicle, who's doing what, who's entering information, who isn't. Um, Matter of fact, I just did today, which is somewhere here on the page. I have my beacon stuff because I wanted to know, you know, what happened for the month. And I know can tell you that I think there were 21 responses uh, to active scenes for the month of August. Yeah, August.
That sounds about right.
For the month of August.
So
So
tell us more about your street outreach teams. What's a day in the life? How do these work? I mean, because this is really boots on the ground. This is where you are having a real, tangible, undeniable impact.
this is where we will continue to lead because this is just essentially what we do. This is what separates us from the pack. Uh, I tell people my job description is very easy. It's very simple. There's I think four steps to my job description. One, go out in the community, find out what people need. You go into their communities, you find out what they need. Two, you provide them with those tools and services that meet those needs to the best of our ability. And then three, you show up again tomorrow and you do the same thing. And the fourth and the most important, don't be an asshole. You know, um, w- we exist because of them. Uh, we learn about services and service provision based on what they tell us. So, and they tell us how we do that. So, without them, there is no us. Um, so, and oftentimes, we may be the only person they encounter, especially my actively using uh, drug participants. In the course of a day, we may be the only person they meet that does not have an agenda. Save, what do you need, and how can we help you?
Powerful. That's really
Uh,
powerful. How does it work in terms of where do you decide to go? I mean, you've got the RVs, you said now 5 vehicles with teams in each of them. What's their mandate, right? They come to work in the morning, they get the keys, they make sure the RV's got gas in it, and then what happens?
well, it's gotten a lot more complex than that, now. Uh, at any given time, the RV is a beast unto itself with a staff that, uh, they exist in the field. They don't come in unless we have a meeting or unless I go out there. They have a set hours, they have a set uh, path, if you will, and they go about it. I have a nurse on the RV and two other staff members. Uh, they, as we seek to meet folk where they are. If that's some uh, assistance with wound care with the nurse, uh, referral to medical providers, again the syringe exchange. We always have some type of snacks or something to drink. You know, and the RV also has the ability to respond to what separates it in addition to being able to connect people on demand to treatment, uh, medication assisted treatment. We can also respond if for whatever reason a doctor's office was shut down as a result of being found to be a pill mill, which has happened. We can show up on site at that doctor's office. And as people begin to show up for prescription refills, we can engage them. We can divert them from the office to the RV, engage them. We have a set of medical providers who are on standby to stand in where those other places weren't, so that uh, we can you know, begin to wean them down because oftentimes the prescriptions are way above what they would normally be in a safe level. And for those who are on benzos, you can't stop a heavy benzo script and have them go cold turkey. It could be dangerous. The same for opioids. So, again, if there's a breakout or a rash of overdoses in any one area where you know we can respond to that area to make sure we're dispensing naloxone. We can do drug checking. We now have we're about to receive an FTIR, but we have another machine that came out of Canada, which is a Raman technology, which can test for the presence of, or it can test drugs. It can, so we're able to test drug trash samples and find out what's in the supply. Um,
What's an
and
FTIR? Sorry, for those of those us, including me, who don't know.
the FTIR is made by Bruker. It's actually infrared. The FT is, I forget the fancy name for it, but it's an infrared technology that allows us to use very, very small samples of a compound, generally a powder, and tell what's in that sample. So we're able to provide in real time or in near real time information about the drug supply, which is valuable to our participants because it alerts them to say, hey, one, be careful, and then we have a set of a protocol, if you will, that we let folk know, listen, if you're going to use, don't use alone, do a tester. Possible there could be some of these side effects as a result of what we see in a particular sample or not. Uh, but again, information empowers the participant and allows them to make healthier choices that could prove to be life saving.
So I'm looking here. Fourier transform infrared spectroscopy. There you go. There's a Jeopardy clue.
That's the Bruker Alpha.
Yeah, FTIR sounds easier. So you started getting naloxone in 2014, and it was made available to the public in Connecticut in 2014. But like you said, it wasn't widely available for quite a while.
2017, you know,
Yeah.
even then, again, because of some of the people who were in leadership positions. At the time, there were probably three, initially two, three types of naloxone available. Again, intramuscular, which at the time, uh, my brain is drawing a fog right now of the company had that owned the rights to that intramuscular naloxone, but Pfizer brought the company. Pfizer brought the company very early, I think in 2016. Uh, Pfizer bought the company. There was the Amphastar three-piece, which was a 2 milligram dose. It was three pieces to put it together. And then we had the Evzio auto injector came, and that at the time was about $2,500 per kit. The Amphastar was about $70, uh, depending on where you got it from, between 40 and $70. The intramuscular was a $16 per dose. And then Narcan, nasal Narcan by the brand name Narcan, came onto the scene. So, but for the initial part, um, Connecticut did not go with the nasal because, again, of leadership in those decisions from those folk. They went with the Amphastar, so their money didn't go far because they didn't have huge budgets for it. Where the intramuscular would have been a hell of a lot more cost effective. And so, arguing early on to have enough medication to make it sustainable, because why would you give out medication for a month, run out of it, and have to wait 5 months to get more when you can spend the same money and have medication to give out through that whole time period? So, it's always been, uh, it wasn't until actually last year, although we've been blessed that we've always had access to naloxone from the very onset. We've been giving it out. We've had the longest continuous running overdose prevention trainings, and just made sure people had access to this life-saving drug. And why not? It had no side effects. It has no side effects. The only side effect to naloxone is that it saves lives.
Yep. We talk about that with people a lot, that the side effects from CPR are catastrophic, if not sometimes fatal, or they can be. We talk about misadministration of epinephrine, like an epi auto injector. Side effects of that can be catastrophic, if not fatal. Um, but with naloxone or Narcan, you can pump someone full of that all day long, and nothing's going to happen to them.
Yeah,
So,
yeah.
so you and I, we first met back in 2018, 2019, and we were trying to get these programs started for opioid overdose response networks. And the whole premise was that there are a ton of people walking around with naloxone in their pocket, but they've got no idea when there's an overdose. And so we went around and talked to hundreds of potential partners to find out, would you like to work with us on a program where when an opioid overdose is reported to 911, an alert is sent out to community responders with lived experience carrying naloxone to alert them where the overdose is, and allowing them to possibly get there before 911. Because, as you're well aware, one of the things about opioid overdoses is that seconds really count. Just like in cardiac arrest, if the heart isn't pumping, no oxygen is getting to the heart, and therefore the heart is dying. And the same thing in opioid overdose. If someone is not breathing, then oxygen is not getting to their brain, and they're suffering brain damage. The longer they're not breathing, or they're not breathing adequately, because as you know, in many opioid overdoses, they're breathing, but the respirations are shallow. There's not
Yeah.
adequate perfusion. So with just like cardiac arrest, opioid overdoses, seconds count. And so we were saying, look, if you can get people there quicker than 911, then that's going to help outcomes. But we had a lot of trouble getting people to start this program with us until we met you. And I remember the first conversation we had, you said this is a no brainer. And we got started. And I wish everybody we talked to after that said the same thing, but it hasn't happened that way. But you've now been running this program for about, we're going on close to 3 years, I think. I remember exactly when it started was I went to Hartford to give the final training to the responders. And the whole time this was February, March of 2020. And I remember the week before that, I was so spooked because we were watching the news with this COVID thing. And I was like, oh no, we're gonna get this canceled. It's gonna be too risky. And then if we don't get this program up and running and this turns out to be a really bad pandemic, it'll be years before this program gets started. And I remember calling you up and being like, really nervous. So, Mark, are we still on for the training? And you said, absolutely. And I remember I raced up there, gave the training. I got back in the car and I was driving back to my brother's house. And I turned on the radio and there's Governor Lamont saying, we're going on lockdown. And I remember thinking, wow, well, we've done our part. If they don't launch the program, totally understood, but fingers crossed. And then in that first month, you responded to 60 overdoses. Tell us about this program. How does this work? What does it take? Who's involved? How does it work?
It really, it doesn't take a lot at all to run the program. It's all text based, so you don't have to have any special equipment, save a telephone that receives text messages. Um, we, there are a couple of different ways by which, well, three ways off the bat, because we developed things and, this was one of the first things we did. Like I said, having that background in printing, we tell our people what we're doing, and oftentimes they'll let us know. Then we came up and we printed some some bands. I don't know if you remember these. It says, "Don't run, call 911." You
Absolutely.
know, or call this phone number here, and we'll call them for you, and and save a life. It just really that simple. Uh, we knew that 80% of overdoses happen in the presence of someone else. They're the true first responders, those folk that overdose. And how do you respond? Well, we figured out and knew from our polls and from speaking to people, the number one reason people did not call to report an overdose was fear of police or prosecution. They didn't know the rights, they didn't know about Good Samaritan laws. And so that's, how we were able to inform them. And we said, you know what? Well, if you're scared, call us and let us call, which is one thing that we do whenever we encounter an OD, whether it's us responding or someone called us and we respond, we likewise call 911. So, you know, initially people were waving us down and pointing their finger, because the way our vehicles are, we already have what's called an on demand program. So anytime anyone sees one of our vehicles and the flags, we have flags that are fixed to the rear of the vans. When anyone sees those flags, or at the time I still had my Sprinter, uh, and they'd flag me down in whatever I was driving, and do one of those numbers, and we knew what that meant. or we had, you know, an individual who's sitting around bored listen to 911, to listen at the emergency responders, over through the scanner. And it was very easy because anytime something was going to happen, there's a tone, a special tone. So even if you're not listening, your brain keys into when you hear that tone. And when you hear that tone, you drop an ear in and then it'll say what's happening. And then all that dispatcher has to do is key in what they heard, at the location to the best of their ability. And then the beacon would then list to or shoot a text to the responders. And the responders were my staff. The responders were participants who agreed to be a responder, because they're always out in the street. And then they get a text, and that text, comes up and is real easy. And I'm surprised it hasn't gone off while we've been on this call.
So the text goes out, people respond, they arrive on scene. Sometimes they get there before police, fire, EMS. Sometimes they don't.
Yeah.
How does that work? How is that? Because some people are like, well, why are you going when 911's already on the way? And like we said, it's because if you can get there before 911, seconds count. But what happens if 911 is already on scene? Do they?
Oftentimes, when people come back from an OD, they're confused. They, depending on the environment and the individuals, they won't be very forthcoming to answering questions. And quite often the people are known to us, so we're able to assist and, say, hey, how, again, how can we help? Uh, there we go. I know I can't tell you I don't have Beacon. So it'll come up and it'll say, hey, alert, and it'll give the location. And then the person just keys in on that location and assigns a number. And that number may mean the amount of minutes it's going to take them to get to that site. And then Beacon will automatically say, whoever answered with the lowest amount of time, you respond, and then that person responds to the site. They key in when they arrive on the site, then any other notes. And then when they finish at the site, what happened. It's really just that simple. And, what happened as a result of us showing up to so many sites, uh, EMS and fire at sometimes had an attitude like, who the hell are these people? How do they keep showing up at sites? And why? And so the health department said, "Oh, that's Greater Hartford." One of the EMS guys, Pierre Canning, said, "Oh, that's Greater Hartford." That's what they do. They're on top of things. They have people out here, uh, and that led to conversations uh, between fire and EMS, and we developed a network which came or became our opioid task force. you know. Uh, while it was EMS, fire, and us, I'll tell you, we had a really good rapport between fire and EMS. Now, once the city at large came into that fold, it took a different direction. It still has. We're still a part of it, but it's not the same as when we began to get together and talk about how can we collaborate, how can we further make sure that we can save lives, you know. And I introduced them to the beacon system because they couldn't understand how we could respond to scenes quicker than them. And they're flying with their lights and sirens and everything else. And I'm saying because we have people who are in the field at any given time 12 to 14 hours a day. So sometimes it's a lot easier if we're out there to move. But I remember early on, it was not unheard of for me to come from across town to the south end and still beat people to the scene. It just wasn't. It's gotten a lot better, but we have to do everything we can to reduce the number of fatalities as a result of overdose. And this has proven to be one of those means by which is another tool in that toolbox.
So I'll play the devil's advocate here because I get these questions all the time, and I'm sure people listening will have the same questions. And I just love for you to answer them because you can better than I can. But the number one question we hear about when we propose this program is, what about the safety of these responders, right? What I remember one person said to me, someone with a public safety background said, "You are sending people with good intentions into harm's way. These are dangerous scenes, and they should only be responded to by trained law enforcement professionals. And if you're going as EMS, you should only go with law enforcement there on scene with you." How would you respond to that?
I told you, be careful. I forget this is going to be rebroadcast, so you'll probably have to bleep that out. Bullshit. And not many words or responses you can say. Ludicrous. Unproven.
Well, so what they'll say is, when you have resuscitated someone who had just been, you know, overdosed on death's door, and you administer Narcan, then they become violent and aggressive, and and they will start attacking people.
Again, bullshit. In all my years, and I've lost count of how many overdoses I've reversed. Uh, you know, and I'll say, due in part to this Beacon app, we found ourselves that in our drop-in center, responding to overdoses in that general vicinity of our office, and no matter, and none of my staffs, not just me, we've reversed hundreds of overdoses, and never have we had someone get violent. You know, when the one thing again I will say that separates us from the pack is the fact that we our services are all non-judgmental, uh, and there's a level of care that goes along with our work, so people know our intentions. I will say, when people have when law enforcement is present, people are agitated. They're already, in some cases, naloxone removes opioids from your system. You come to unaware maybe what happened. Now you've got police, you've got all these people around you asking questions. And then some of them, quite, frankly, can be assholes, you know? And then you wonder, you one response deserves another. When you have someone who's agitated, not sure what's going to happen, yeah, probably some negative things have happened, but for the most part, again, a lot of other people just repeat shit they heard from others. I know people who've never reversed an overdose, but they'll say, "Be careful because when they come back, they'll be volatile, they'll be angry, they could be violent," and it's like, "Fuck you." Have you ever reversed an overdose? And has that person been violent? Stop repeating things you've heard. It's hard to, once negative information has been perceived from trusted sources, it's taken as fact, when in fact it's false information.
So on that comment, can you please respond to these videos that are being passed around of a police officer touching fentanyl and immediately keeling over? What's that all about?
Bullshit.
Uh,
Hys-
what are we
Hysteria.
really seeing?
There are a couple of phenomenons that, listen, I tell people, don't take it for fact from the large black guy. You don't have to. But there are medical professionals from Harvard to Yale to Istanbul that will say it is medically impossible to overdose from touching that product just like that. Now, listen, I've got bags upon bags upon bags of fentanyl, all product, purple, white, brown, and I handle the bags. For some trainings, will rub my hand. I don't ask anybody else to do it, but just to prove the point that it's misinformation. Misinformation from trusted sources. Now, there is and has been shown that anxiety, it's been more of an anxiety attack.
A panic attack.
That why those folk went out. It's like, what? I touched it, and then boof.
Yeah.
But was it in fact? And here's the deal. And I have, information from, the prestigious medical institutions, from the CDC, from the ONDCP, which is the Office of the National Drug Policy Council, Office of the President. Uh, all of these things that state that, you know, you can't OD from touching it.
So there's actually, I just read someone published an article. It was like a pharmacologist, and basically he spilled a gallon or gallons full of liquid fentanyl, or maybe it was the dust itself, but he spilled a whole bucket of it on himself when he had open cuts on his arm and nothing happened. And so he published it in some medical journal recently.
Yeah, there was one out of Liverpool, Ohio, where the police officer supposedly frisked the individual, and the dust that came off of his clothes, the officer OD. Poof. They came back and said medically impossible, nonsense, bullshit, the whole nine.
I think the first one I read was San Francisco PD, which surprised me because you would think that they would be up to date on this stuff. But San Francisco PD apparently made a drug stop on the Golden Gate Bridge. I could be making this up, but this is how I remember reading it. Is they made a drug stop like on the Golden Gate Bridge, and then as they opened the car door, fentanyl dust escaped. The man started to feel tingling in his lips and in his fingers, and he hit the ground and luckily was able to pull Narcan out of his vest and self-inject himself before he overdosed, which in and of itself would be a first as far as opioid overdoses are concerned. But when you hear tingling lips and tingling fingertips,
I say cocaine.
You would say cocaine. I would think a panic attack. Like, chill out, like get your breathing under control. You're blowing off too much CO2.
Breathe.
A paper bag. So thank you for sharing that. I get sent these videos a lot, but that's not to underestimate the danger of fentanyl.
No, not at all. Not at all.
Because
And
fentanyl,
and I tell people, if you get it on your hands, wash your hands with soap and water. Don't use alcohol. Don't use hand sanitizer, because alcohol is the way that, like, fentanyl patches are used to help permeate the dermis. So you don't want to do that. You just simple salt, soap and water. Soap and water. Wash your hands.
yeah. So fentanyl is obviously a huge problem. Uh, how do you think that we're going to solve this, or at least tamper it?
The only way to truly get these deaths down would be to get more heroin immediately back into the market, or a product that is more pharmaceutical based. Uh, what makes fentanyl so dangerous is the way it binds to itself, and the various analogs that are coming out is what makes fentanyl so dangerous. Uh, Combined with the market, it's a marketable product. Right now, there's money to be made by everybody. And it is such and so marketable that it's not going away. Heroin, on the other side, is a more stable product. Dilaudid pharmaceutical grades of heroin are more stable. People are going to use regardless. People have been using drugs to change their frame of mind since the beginning of time. Since early man, people have found ways to change their mood and mind, their state of being. Um, Fentanyl is only going to, and things are only going to get worse, even as we have pills. I don't think we've entered the fourth wave of this epidemic, because uh, the pills haven't caught on. The, the counterfeit pills. Listen, the United States makes up 5% of the world's population, yet we consume upward of 80% of the world's prescription drugs, the pharmaceutical, the painkillers. All right. What that is a market. It's an insatiable, multi-billion-dollar market. Well, if you can take a $5,000 investment, buy a pill press, and flip that into $1 million return, are you freaking kidding me, Jason? We th- Listen. Everybody makes money, and we're a capitalistic society where the first rule of business is market. And if we couldn't stop bootleg Nikes or bootleg CDs or bootleg purses, how do you think we're going to stop a bootleg Percocet? You know, how are we going to stop? The bootleg oxys, the benzos, anything? We're in for it. So, yes, will some things like saturating towns with naloxone and reaching that saturation point, will it help? It will help. Removing the stigma of helping people address overdose and responding to overdoses will help, because, again, the great majority of overdoses happen with someone else present. But what happens by reducing the stigma, by understanding that these are not moral failings? 4 out of 5 people now who suffer from a substance use disorder happen, they started with pills as a result of injuries or surgeries, things of that nature. And it has progressed. Um, will overdose prevention sites be another method by which we're able to engage people and get them into medication assisted bases or modes of treatment? There are a lot of things, but let's be frank, uh, we're going to experience a lot more loss of life unless we begin to reduce stigma and begin to meet this right where it is.
So you're advocating for decriminalization or legalization.
A
Better
better
to
drug supply, a
better to
better drug
regulate it,
supply.
manage it, than leave it to the black market. Yeah, certainly a strong case for that because the
Well,
traditional ways haven't worked so well.
the most effective public health responses are not favorable. They're not. They offend our morals. They're seen as enabling.
So
They're
that's my next question. How do you we talk to people about the overdose response program, or we talk about getting programs so that community responders can guide people to medicated assisted treatment, kind of navigators, so to speak. And a lot of the pushback that you hear is you're enablers. How do you respond to that? That you're, so you and I'm just going to be again the devil's advocate here. When I was working on the ambulance, I would hear this from coworkers was we reversed the overdose today so that they could overdose tomorrow. How would you respond to that?
okay. Reverse it again tomorrow. You're getting paid. You know. Um, Listen, folk who are suffering substance use disorder from opioids are using once they experience that are oftentimes are not using to get high. They're using to keep from being sick. And so to keep from having a paralyzing negative effect of not having that drug, they're now using that drug and for whatever reason, you know, treatment may not be an option because of insurance. It may be that they've had issues. It may be that they're scared of the withdrawal as that they've experienced in the past. Uh, there are any number of reasons or barriers. We have to figure out how to really work with people and either reduce those barriers or find ways to keep them safer, you know, until some other form. And that's really what harm reduction essentially is really trying to help people manage their use until some other method to keep them safe until some other viable method presents itself, either through conversation, repetition of messaging, or after an overdose. Sometimes people will change behaviors after a life changing incident. Uh, but the bottom line is we, we have to continue to do it. We have to do it until something catches, or else, we're going to lose. We're going to lose more and more people.
Absolutely. A lot of truth to that. A lot of truth to that. So now, Greater Hartford Harm Reduction Coalition evolved. Now the Connecticut Harm Reduction Alliance. What's your immediate goals and what are you hoping to achieve in the near future?
Uh, Community center. Um, One of the negative effects or impacts of COVID that hit the urban center was the closure of churches and spaces that hosted 12-step fellowship meetings. They've created bigger food deserts, um, and many places that provided evening meals and things of that nature are no longer available. Um, we have to begin to connect people. If the opposite of addiction is connection, COVID separated us even further. If the opposite of addiction is connection, then we have to begin. We we're not doing that. We have to begin to connect people again. You know, I mean, what did the governor and the president say? This thing is over now. COVID, the pandemic is over. You know, yeah, but nobody believes it. They're not hearing that. They're not hearing that shit. Nobody. Yeah, okay, we may not have masks and things on the daily and all the time now, but nobody jumping out the window to go, open up all of the places that have been closed. They want to err on the side of caution. So, in the meantime, man, there are a lot of services and things, but I mean, we want to continue to do what we've done, and that's uh, to expand access to harm reduction best practice. And we've done that, man. I mean, now we've got hospitals that give out our syringes. We have FQHCs now that are giving out, harm reduction packages and best practices. We've got a hospital infectious disease clinic. We've got OTPs. We've got rovers now in the VA medical healthcare system in Connecticut. We've got the VA giving out freaking needles. These are things that these are milestones and beginning to help people understand the necessity for harm reduction best practices and as engagement tools, not in enabling or things tools to enable, but tools to engage. You know, you can give away a business card all day long till you're blue in the face. People get them, they toss them, they put them in their pocket, so be it. But when you give out something such as that has value to that individual, that has value and says that you care about their health and welfare, well, now you're establishing a relationship at a different level. Even, now some first responders are able to give out Narcan after they leave a scene. For some of those companies, we've given them overdose care packages, which also have syringes and information in them. We have to, get it and do it at every level we can.
It's awesome work you're doing. I mean, it's really awesome work, and it's work that a lot of people would rather not be doing. So it's awesome that you're there and looking out for the folks who are easily overlooked, purposely overlooked.
Well,
So,
it's because of people like those two right there behind me. Both of whom are no longer with us. They were some of the early pioneers in this state that they also sold me on this work.
so for anyone who's looking to get involved, right? I mean, you're truly a community response organization because you are responding to the community's needs. For other people who are looking to do the same, and we need lots of them, can you give some high level, some kind of principles, things that have worked for you throughout the years despite all of the setbacks, and a secret, the setbacks never stop, right? The more success you make, the bigger problems you have to face.
Yeah.
Can you come up with one or two principles, or just guiding principles that you could share that have worked for you?
Stay true to your work. If you believe in it, um, always seek to better yourself, better your product, better the presentation, whatever, communication, education, information, repetition it doesn't always happen the first, second, or third time. You have to keep plugging. You have to keep plugging. And in the instance of harm reduction, of showing the value, there's value in the work. Um, you're going to hit roadblocks. Again, I hit roadblocks every day, every day. It's what has shaped my work is how I've learned to sidestep and respond to that pushback, to those issues, is what has given or provided the level of success that we now are able to uh, elevate our work and continue to reach people. Is because we keep our feet on the gas, if you will. We're not resting on our laurels. We keep our feet on the gas.
Excellent advice. I can 100% relate to that. Every time I open up my email, roadblocks, just lots of them. So, and I can tell you personally, many times I've asked myself, is this all of this work? Is it worth it? And I'll tell you the one thing that keeps me going is I believe that this works. Like you said, I believe in it. What we're doing, I can't imagine doing something that I didn't believe in. I wouldn't do it.
Yeah.
So that kind of conviction, almost maniacal conviction, is going to take you a long way. Well, Mark, I thank you so much for your time. As always, it's a genuine pleasure. This has been really informative. Always great to hear, and hope we can get a lot of people listening to this because you've got such an awesome story.
All righty. I appreciate it. Thank you for inviting me.
Absolutely. We will be in touch. Take care.
Jason.